Okay, let's dive into a clinical area that demands our sharpest focus and quickest action: necrotizing soft tissue infections. You brought some essential source material to this deep dive, specifically excerpts from a definitive text on the subject by Drs. Anderson, Jacoby, and Fum. Our mission today is to go deep into this text, really extracting the vital knowledge and clinical insights you need to tackle these incredibly challenging cases.
That's absolutely right. Necrotizing soft tissue infections, often dramatically referred to as flesh-eating bacteria in, wider discussions, represent a group of clinical disorders that are rare, yes, but extraordinarily complex, and they carry immense stakes. They're characterized by a rapid, often just devastating progression, leading to significant morbidity and critically very high mortality rates.
The urgency is just palpable with these infections. So, guided directly by the source material, we're going to unpack the critical nuances. We aim to provide you, the specialist clinician listening, with a thorough understanding by exploring their history, the underlying mechanisms of how they cause such damage, how they're classified, the best ways to recognize and diagnose them, and then delve deeply into their management. With a particular focus, of course, on the role of adjunctive hyperbaric oxygen therapy, which is a key area of discussion in the source text.
It's a crucial journey through this material, I think, given the impact on patient outcomes. We'll start by looking at the historical context and the fundamental rationale behind our current therapeutic strategies. Then we'll dissect the complex pathophysiology, the how and why these infections progress so aggressively. After that, we'll classify the different types and causes, discuss the diagnostic approach to recognizing these often subtle but rapidly evolving presentations, and finally spend significant time exploring the clinical management, including, yes, the nuanced role and evidence surrounding adjunctive hyperbaric oxygen therapy.
Okay, let's begin by going back in time, as the source text does, starting with the introduction and the rationale behind our current approach. The initial descriptions of what we now understand as necrotizing infections date back surprisingly far, actually, even to the American Civil War era. In 1871, Dr. Joseph Jones, who served as a surgeon for the Confederate Army, coined the term hospital gangrene to describe a huge number of severe cases he encountered, something like over 2,600. This historical context immediately sets the stage, doesn't it? Highlighting the potential for these infections in challenging medical environments.
It really does. And the terminology and our understanding evolved over time. In 1883, Dr. Jean-Alfred Fournier specifically described necrotizing infections that occurred in the perineum, and that specific anatomical presentation is still recognized today as Fournier's gangrene, a distinct form of this disease process. The term necrotizing fasciitis itself wasn't the original name, actually. The illness was initially characterized and named hemolytic streptococcal gangrene by Dr. Frank Millenny back in 1924. He described it as a condition involving gangrene of the subcutaneous tissues, followed by, very rapid necrosis of the overlying skin. Critically, he noted that this extensive involvement reached deep into the fascial layers.
Mullaney's work was also pivotal in identifying the microbial link, right? His description tied the illness to a specific bacterium. It was associated with hemolytic streptococci found in cultures taken from these patients. He also observed that all the patients were severely ill, highlighting the systemic nature even back then. What's striking, as the source points out, is that even Millenny's early observations pointed toward the most effective treatment: surgical extirpation. That's the aggressive removal of the affected tissue. This principle, removing the source of the infection by cutting out the dead tissue, remains remarkably the cornerstone of therapy today.
It really underscores the fundamental importance of source control. It hasn't changed. The modern term necrotizing fasciitis wasn't formally attributed until much later, specifically to Dr. Wilson in 1952. And yes, the term flesh-eating bacteria remains prevalent in broader media discussions, capturing the dramatic and rapid tissue destruction characteristic of the disease.
Moving beyond the history, what's the current scale of the problem? The source provides some incidence data. The annual incidence of necrotizing soft tissue infections varies, but reported data suggests it's around 4 per 100,000 individuals in developed countries. Which sounds like a low incidence, but the severity was reflected in the mortality rates. A significant multi-center study cited in the text, involving over 400 patients, reported a 90-day mortality rate of 18%.
18% at 90 days. That's a substantial mortality rate, reflecting the aggressive nature of the illness. Confirmed cases, specifically in the United States, show a similar picture, with the overall mortality rate approximating 20%, according to the source. This data really reinforces why treating physicians and surgeons consider these infections among the most difficult disease entities they face. Their ability to produce considerable tissue damage in a very rapidly progressive manner highlights the immense importance of timely recognition and the immediate initiation of aggressive therapeutic interventions. Time truly is tissue in these cases. There's just no getting around that.
And as the source rightly notes, the focus isn't solely on immediate survival, although obviously that's the priority. Reducing post-survival morbidity, the long-term damage and disability, and optimizing survivor quality of life and eventual reintegration into society are crucial facets of care that extend well beyond the acute phase. These aspects, the text points out, are sometimes neglected in the broader trajectory of managing these patients.
That's a really important point. With that foundation, the text pivots to a key area of discussion: the rationale for adjunctive hyperbaric oxygen therapy. The source states that the adjunctive use of hyperbaric oxygen therapy in the treatment of necrotizing soft tissue infections remains an accepted modality. It's used not in isolation, but in conjunction with judicious surgical debridements, which, again, are the absolute foundation alongside broad-spectrum parenteral antibiotic therapy and a comprehensive multidisciplinary approach involving various specialists.
So, to fully understand why hyperbaric oxygen therapy is considered, the source emphasizes the need to explore the underlying pathophysiology, the biomechanics of tissue damage, and the risk-to-benefit stratification for its use. It brings us back to the principle that surgical debridement remains the undisputed mainstay of current therapy for necrotizing soft tissue infections.
A point the text is very clear on, even while acknowledging the limitations in current research surrounding that critical surgical step. Despite surgical debridement being the cornerstone of treatment, it notably lacks, adequately powered, randomized controlled studies to guide specific practices. There's a lack of uniformity or specific guidance detailing exactly how early debridement should be initiated, precisely how extensive debridements must be, and what the optimal frequency or interval between each debridement should be. These specifics, the source notes, are critically lacking in the literature. We just don't have strong data to pin those down.
That variability extends to antibiotic therapy as well, doesn't it? A review of the existing literature, according to the source, reflects wide variability and ongoing debate regarding both the selection of antibiotics and the optimal duration of treatment. However, despite these discrepancies in areas lacking definitive evidence, core therapeutic principles remain universally accepted. Any therapeutic effort must effectively debulk necrotic tissue and combat systemic infection. These are absolutely critical, non-negotiable principles of care.
Absolutely, but the source highlights that effective management needs to go further. Orchestrated efforts must also target the underlying biological processes that contribute to the disease. We must target the pathophysiologic contributions of the underlying widespread tissue hypoxia and inflammation that fundamentally characterize necrotizing soft tissue infections. And this is precisely, the source argues, where the use of adjunctive hyperbaric oxygen therapy plays its role. It is intended to directly target these specific pathophysiologic aspects of the disease process.
Okay, so let's consolidate the key points from this introductory section. We've traced the history from hospital gangrene to necrotizing fasciitis, emphasizing that aggressive surgical removal of tissue has been the core treatment since, the beginning. We highlighted the significant mortality rate, around 18 to 20%, despite its relatively low incidence, stressing the need for timely, aggressive intervention and considering long-term recovery. We introduced adjunctive hyperbaric oxygen therapy as an accepted part of the multidisciplinary approach used alongside essential surgery and antibiotics. Crucially, the source points out the lack of strong evidence, those randomized controlled trials, guiding the specifics of surgery and antibiotic duration, but emphasizes that targeting the underlying hypoxia and inflammation, which hyperbaric oxygen therapy aims to do, is also a critical part of comprehensive care.
Exactly. Now let's transition into section 2 and delve into the pathophysiology, understanding exactly how these infections cause such rapid and extensive damage. While many clinical scenarios, specific lesions and syndromes associated with necrotizing soft tissue infection have been described, in all these diverse situations, the common denominator, the underlying engine driving the destruction, appears to be the development of tissue hypoxia and inflammation. This combination is what ultimately results in widespread tissue necrosis.
So hypoxia is absolutely central to the process, and this lack of oxygen has a direct and, detrimental impact on our immune system's ability to fight the infection. Phagocytosis, that vital process where our white blood cells, the polymorphonuclear leukocytes, engulf and destroy bacteria and debris, it's significantly impaired by hypoxia. They simply cannot perform their job effectively in that low oxygen environment.
That's a critical early step in the cycle. Once an effective process is initiated, the metabolic products generated by both aerobic and anaerobic bacterial metabolism lead to a significant drop in the local pH. This acidification creates a hostile local environment for our own tissues, but a milieu that is particularly favorable for the growth of strict and facultative anaerobic organisms, precisely the types often heavily involved in these infections.
And the blood supply is key to how it spreads, right? When the blood supply to the overlying skin and subcutaneous tissue is affected. And this happens due to the involvement of blood vessels running through the deep fascial layers where the infection often starts. Compounded by the formation of a phlegmon that diffuse inflammation and the edema and necrosis within those deep fascial layers, there's a decreased perfusion pressure. This reduction in blood flow leads to ischemia in the overlying tissues. This ischemia, this lack of oxygenated blood, then strongly predisposes to the very rapid progression and advancement of the infectious process, not only within the deep tissues, but outwards into the skin and the subcutaneous tissues.
And this rapid spread is further exacerbated by the dysfunctional polymorphonuclear leukocytes we discussed. They just aren't effective at containing the infection in this environment. Local hypoxia also occurs, leading to an upregulation of endothelial adherence molecules on the walls of the blood vessels. This process results in increased leukocyte adhesion to the endothelium and direct cytotoxicity to the endothelial cells, damaging the vessel lining. Consequently, leukocytes become sequestered in the vessels, trapped and unable to migrate out into the tissue to fight the infection effectively.
So local immunity is crippled, and the body just can't clear the infection. This impairment of local immunity, combined with incomplete substrate oxidation in the hypoxic environment, causes an accumulation of specific metabolic byproducts. The source mentions hydrogen and methane accumulating in the tissues. This accumulation is directly linked to the characteristic signs we see later. Tissue necrosis then occurs, often with purulent discharge, and significantly, gas production from the anaerobic metabolism.
Yes, those quantities of gas within the tissues are a hallmark sign and a crucial diagnostic clue, frequently seen in conditions like gas gangrene, crepitant anaerobic necrotizing cellulitis, and necrotizing fasciitis. Now, this is where hyperbaric oxygen therapy directly targets the core pathophysiology. The post-inflammatory leukocyte dysfunction that occurs within that localized area of hypoxia and infection is specifically mitigated by hyperbaric oxygen therapy.
How exactly does it do that?
Well, it works by providing oxygenation to those otherwise ischemic, oxygen-starved areas. This infusion of oxygen helps to limit the spread and progression of both the infection and the inflammation. The mechanism involves the diffusion of very elevated concentrations of oxygen, delivered under pressure in the hyperbaric chamber down a steep gradient. This oxygen moves from the high levels achieved in the blood under pressure to the much lower oxygen levels found in the hypoxic and inflamed tissues. This creates a powerful oxygen gradient pushing oxygen into the damaged areas.
That makes intuitive sense, just getting oxygen where it's desperately needed.
Okay.
And you mentioned oxidative stress earlier. How does that fit?
Yes, the source notes that raised oxygen tensions, particularly under hyperbaric conditions, also provide an oxidatively stressed environment. This controlled oxidative stress, involving the generation of oxygen-free radicals, isn't just damaging, it's actually crucial in this context. It further fuels a biochemical array of healing processes that are driven by signal transduction pathways within the cells.
So it's not just about getting oxygen for basic cell function, but using it almost like a therapeutic signal.
Precisely. The role of oxidative stress in upregulating antioxidant activity, modulating signal transduction, and facilitating healing is well established in other contexts. The source points to recent research in necrotizing soft tissue infection that sheds more light on this. A 2021 observational study by Hedtoft and colleagues involving 80 patients found an associated overall increase in specific markers related to oxidative stress, including superoxide dismutase, myeloperoxidase, and heme-oxygenase 1.
Did they see a correlation with patient outcomes in that study?
They did, interestingly. Elevated baseline levels of superoxide dismutase in these patients were found to be associated with increased 90-day mortality. The authors of that paper made a key observation. In patients with necrotizing soft tissue infection-related septic shock, hyperbaric oxygen therapy appeared to stimulate the endogenous production of anti-inflammatory cytokines and enhanced antioxidant defense mechanisms, specifically by upregulating heme oxygenase 1. This particular process has previously been shown to improve survival in both preclinical polymicrobial models and in human sepsis.
So this suggests a potential dual role for hyperbaric oxygen therapy in necrotizing soft tissue infection based on that study.
Exactly. The Heidtoft authors proposed that hyperbaric oxygen therapy simultaneously serves two critical roles in necrotizing soft tissue infection. Firstly, via the oxidative stress response it induces, it augments bacterial death, particularly in non-shock patients. Secondly, it plays a crucial role in regulating the robust inflammatory response seen in patients who are in septic shock secondary to their infection.
Beyond these direct effects on tissue and inflammation, the source mentions another potential benefit related to antibiotics too. Hyperbaric oxygen therapy can act to enhance antibiotic penetration into target bacteria. This is particularly relevant in cases where the specific antibiotic being used requires oxygen for transport across the bacterial cell walls.
Yeah, that's an important synergistic effect. A specific example provided is the enhancement of the post-antibiotic effect by hyperbaric oxygen therapy for aminoglycosides, especially when used to treat Pseudomonas infections. This synergy can be clinically quite important.
That's a really detailed look at the destructive processes and how hyperbaric oxygen therapy might intervene. So to consolidate Section 2, the core pathophysiology involves this vicious cycle of tissue hypoxia and inflammation, which impairs immune cells, creates an acidic environment favorable to anaerobic bacteria, compromises blood flow, and leads to rapid necrosis and gas production. The source explains how hyperbaric oxygen therapy directly counteracts this hypoxia, improves immune cell function, and creates controlled oxidative stress that may aid healing and modulate inflammation, potentially even enhancing antibiotic effectiveness.
Excellent summary. Let's move now to Section 3, focusing on the clinical classification and etiology of the disease. Classifying necrotizing infections of the soft tissues based purely on clinical presentation can be, well, quite difficult. It absolutely requires a very high level of clinical suspicion to even consider this diagnosis early on. Ideally, classification is best achieved early in the course of infection, where the contiguous spread might still be somewhat limited, allowing for a clearer picture of the primary organisms involved and the initial tissue planes affected.
And how do we assess the extent of involvement? The source emphasizes assessing involvement at different anatomic levels: the skin, the superficial fascia, the deep fascia, and the muscle. This assessment can be done visually during surgical exploration by obtaining a punch biopsy for histological examination or through radiologic investigations like CT or MRI scans. However, a significant challenge arises as the infection progresses rapidly, doesn't it? The distinction between some clinical entities becomes blurred because full-thickness necrosis can extend into muscle later in the disease course, but only after it has already spread through the skin, fat, and fascia.
Right, this deeper muscle involvement can happen via direct extension of the infection. At an initial presentation, it can be genuinely difficult to definitively differentiate one type of necrotizing soft tissue infection from another, or even distinguish them from conditions like clostridial myositis and myonecrosis until a gram stain or cultures from the affected tissue become available to identify the specific organisms driving the process. However, considering these historical differences in how the infections were described and the evolution of our understanding is clinically useful. It helps us anticipate potential pathways of extension, anticipate the complications that are more likely to arise with certain types, and importantly, helps identify when adjunctive hyperbaric oxygen therapy might be most strongly indicated based on the suspected or confirmed microbial etiology.
This brings us to a key point of diagnostic complexity: differentiating between necrotizing fasciitis and necrotizing myositis. The source is clear on the fundamental difference. Necrotizing fasciitis chiefly involves the fascia, whereas necrotizing myositis involves the skeletal muscle tissue itself. The source explains that the rapidly progressive destruction characteristically seen in necrotizing fasciitis is a direct result of deep soft tissue hypoxia, specifically affecting the fascia.
And this is linked to the blood supply, or rather the lack thereof in the fascia. The characteristically poor blood supply of the muscle fascia stands in stark contrast to the more abundant arterial supply to the muscle tissue. This difference in vascularity contributes to the vulnerability of the fascia to infection and ischemia. This phenomenon, the source notes, has been well described, for instance, in earlier work published in Archives of Surgery by Guzal and colleagues. Because the characteristic level of infection in necrotizing fasciitis is deep at the fascial plane, and the infection and necrosis spread along these planes beneath the skin, it's very common for there to be minimal visible skin changes early on.
So that classic red flag, pain out of proportion to the visible findings, comes directly from this deep fascial involvement.
Precisely. Pain out of proportion to the superficial skin findings can be an early, absolutely crucial tip-off to the presence of this deep fascial infection, hidden beneath seemingly normal or only mildly erythematous skin. Because the blood vessels supplying the overlying skin travel through the fascia, involvement of these vessels by the spreading infection leads directly to that rapid progression to dermal necrosis, causing those alarming skin color changes we discussed as a later sign.
Let's discuss the microbiology involved. The source states that organisms can be isolated from tissue specimens in a high percentage of cases, somewhere between 50 to 90% in various case series. And a key point is that these infections are often polymicrobial. The source notes that one or two organisms often accompany the streptococci in up to half of the cases.
Yes, specific organisms mentioned include group A, C, or G beta-hemolytic streptococcus, with Streptococcus pyogenes being a common and particularly virulent one implicated in up to half the cases. This is associated with conditions like Melanese synergistic gangrene, which is explicitly polymicrobial, often involving anaerobic streptococci alongside aerobes. Staphylococcus aureus, including community-acquired strains of methicillin-resistant Staphylococcus aureus, or EDAMRSA, is also commonly isolated. Other frequently cultured organisms mentioned include various Enterobacteriaceae species, Enterococci, Bacteroid species, and Peptococcus species. The source also notes that Candida species, a fungus, have been reported as causative agents as well.
The source then classifies necrotizing soft tissue infections into bacteriologic subclasses. This classification is based on the microbial etiology, the typical susceptible host populations, and the general presentation. It's important to note, however, that the disease course, along with the associated morbidity and mortality, do not appear to differ significantly between these classes in general. Although specific organisms can certainly impart unique risks, like toxin production.
Exactly. The polymicrobial subclass is often referred to as Class 1 necrotizing soft tissue infection. These are typically characterized by the isolation of at least one anaerobic species alongside an aerobe. Specific organisms commonly cultured in these Class 1 infections include anaerobes such as Clostridium species, Bacteroid species, or Peptostreptococcus species. These are most commonly cultured with Enterobacteriaceae and one or more facultative anaerobic streptococci species, but specifically species other than group A streptococcus.
And where do we commonly see these Class 1 infections anatomically? What kind of patient?
The perineum and trunk are the most common anatomical regions for Class 1 necrotizing soft tissue infections. The typical host population tends to be older patients with greater medical comorbidities. These infections in the perineum and trunk often lack a clear history of frank trauma. Instead, initiating factors like an antecedent perforation, maybe from the bowel, or developing abscess or bacterial translocation across a compromised mucosal barrier. These are frequently responsible for the initial disruption in tissue integrity that allows this polymicrobial infection to take hold.
The source provides specific detail on clostridial infections, which fit into this polymicrobial picture, but are particularly concerning due to their toxins, right? It notes that clostridial infections are becoming increasingly rare, perhaps due to heightened hygiene, like post-COVID hand hygiene practices and improved public sanitation. However, they require strong consideration and extremely aggressive therapy when involved, because their lethality primarily rests with their potent alpha and theta toxins.
That's right. The alpha toxin of Clostridium perfringens, particularly in the early stages, acts as a potent platelet agonist. This causes platelets to aggregate within blood vessels, leading to local tissue hypoxia at the infection sites. This subsequent reduction in tissue pH, as we discussed in pathophysiology, further favors bacterial proliferation. The alpha toxin also directly contributes to neutrophil dysfunction locally by impeding their ability to move through tissues that's diapetesis and their adherence to platelets. This mechanism helps explain the observation of low levels of neutrophils often seen on gram stains obtained from clostridial infections. The toxin actively prevents immune cell infiltration.
So the toxin essentially sabotages the local immune response, making it harder for the body to fight back.
Exactly. Both the alpha and theta toxins from Clostridium act synergistically to disrupt effective phagocytosis by the remaining immune cells. Beyond these local effects, the toxins promote intravascular hemolysis, the breakdown of red blood cells, leading to decreased vascular tone and compromise of endothelial cell integrity, all contributing to severe systemic shock. It's a nasty combination.
The source includes specific types of Class 1 infections, such as head and neck necrotizing soft tissue infections and Fournier's gangrene within this polymicrobial category. For head and neck cases originating often from odontogenic or pharyngeal sources, organisms like bacteroids, fusobacteria, and spirochetes are mentioned.
Yes, and for Fournier's gangrene, the necrotizing infection of the perineum, the causative organisms are typically a combination of facultative organisms like Klebsiella, Enterococci, and Escherichia coli. combined with anaerobes such as bacteroids, Clostridium species, and anaerobic or microaerophilic streptocarci. In patients with cervical necrotizing fasciitis, often linked to dental or throat infections, the chief complication, and a very dangerous one, is descending infection into the mediastinum. Diabetes is highlighted as the systemic illness most often associated with cervical necrotizing soft tissue infections. Interestingly, the source mentions a case series review of patients with cervical necrotizing fasciitis treated with hyperbaric oxygen therapy found a statistically significant decrease, specifically in hospital stay, suggesting a potential benefit in recovery time, although it didn't focus on mortality in that particular review.
Now let's consider the monobacterial subclass, often classified as Class II necrotizing soft tissue infection. This category is characterized by the isolation of a single organism, typically Group A Streptococcus, GAS, or other beta-hemolytic streptococci, or perhaps Staphylococcus aureus.
And the typical host population for these class 2 infections is often different. They tend to be healthier, younger individuals, and they frequently have a clear history of preceding trauma or surgery at the site of infection. In cases without a clear portal of bacterial entry, like a visible wound, hematogenous translocation bacteria traveling through the bloodstream from another site like the throat to an area of prior trauma is thought to be a possible mechanism responsible for class 2 necrotizing soft tissue infection.
And the lethality of Group A Streptococcus, like Clostridium, is strongly linked to its virulence factors, particularly its M proteins. The source explains that M proteins facilitate more effective bacterial adherence to host tissues and, importantly, allow the bacteria to avoid phagocytosis by immune cells.
Correct. But the M proteins also trigger a dangerous systemic response. They act as superantigens, which means they bypass the usual tightly regulated process of immune activation and directly stimulate a large percentage of T cells, something like up to 20%, compared to the typical 0.1% activated by a normal antigen. This massive, unregulated stimulation of the immune system leads to a cytokine storm, characterized by overwhelming systemic inflammation, catastrophic shock, and eventual death. Driven by the massive release of inflammatory cytokines like interleukin-6, tumor necrosis factor alpha, and interleukin-1. The source notes that specific M protein types 1 and 3, are strongly associated with streptococcal toxic shock syndrome in over 50% of cases. That toxic shock component is key here.
Finally, the source describes a third subclass, Class III necrotizing soft tissue infection, caused by gram-negative marine bacteria. The primary causative organism in this category is Vibrio vulnificus.
And similar to class 2 infections, this category often results in earlier signs of systemic toxicity and rapid onset of shock, sometimes even disproportionate to the apparent local extent of the disease. It can hit hard and fast. While infection with Vibrio usually occurs through an open wound exposed to contaminated seawater, the source mentions that infection has also been described from ingestion of raw oysters, particularly in individuals with underlying liver disease like cirrhosis, who are much more susceptible to severe Vibrio infection.
Okay, that provides a solid framework for understanding the different microbial causes and how they tend to present. So to summarize Section 3, classifying necrotizing soft tissue infection relies on clinical suspicion, assessing anatomical involvement, and ultimately microbiology. We highlighted the key difference between necrotizing fasciitis, affecting the fascia, and myositis, affecting the muscle, stressing that fascial involvement drives the rapid spread and the red flag of pain out of proportion due to its poor blood supply. Microbiologically, they're often polymicrobial, that's class 1, typically older patients with comorbidities, often in the trachyperineum, from non-traumatic sources like abscesses or perforations, includes clostridial and Fournier's, notable for toxins, or monobacterial, class 2, often younger patients with trauma, usually Group A strep or Staph aureus, with the GS toxins causing toxic shock, or due to marine bacteria, class 3, involving Vibrio, causing rapid shock.
A good way to frame it. Let's move to Section 4, risk factors. The source identifies the single most common factor predisposing individuals to necrotizing soft tissue infections as a traumatic break in the skin.
So really, any violation of the skin integrity can serve as a portal of entry. This can include a wide range of injuries like lacerations, insect bites, burns, deep abrasions, or puncture wounds. These infections can also follow surgical procedures, particularly those involving potential contamination, such as bowel perforations. Beyond trauma, certain specific comorbidities significantly increase the risk. Diabetes is highlighted as a particularly strong risk factor, as are obesity, chronic alcoholism, smoking, and intravenous drug abuse.
Interestingly, the source also mentions links to certain infectious diseases, noting published reports of necrotizing fasciitis occurring as a complication of infections originating from otherwise typical lesions of chickenpox. Specific medications are also implicated as potential risk factors. Sodium glucose cotransporter 2 inhibitors used in the management of type 2 diabetes are mentioned in this context. And the source notes nonsteroidal anti-inflammatory drugs, or NSAIDs, are implied as potential risk factors.
That link with NSAIDs is presented with a bit of caution, isn't it? It seems controversial.
Yes, it is. The source implies NSAIDs as potential risk factors, but immediately qualifies this by stating that, given their ubiquitous use, a direct causal relationship is unlikely. It's hard to prove cause when so many people use them. However, the text does explore potential biological mechanisms. NSAIDs, which are cyclooxygenase inhibitors, may potentially have an adverse effect on neutrophil killing function and cell-mediated immunity. They are also reported to inhibit monocyte superoxide production, which is important for killing bacteria. Their mode of action, in the context of a developing necrotizing soft tissue infection, may relate to a dampened immunomodulatory effect on leukocyte adhesion, chemotaxis, the movement of cells to the site of infection, granulocyte functions, and overall bactericidal control. So, while perhaps not initiating the infection, they might hinder the body's ability to contain it effectively once it starts.
The source also points to a more specific immunomodulator link. It references a report by Nizet and colleagues, which found that patients with rheumatoid arthritis taking anakinra, a drug that dampens autoimmunity by inhibiting interleukin-1 beta, were found to be 10 times more likely to experience invasive group A streptococcal infections than patients not on the drug. This study really highlights how targeted immunosuppression can dramatically increase susceptibility to virulent organisms, which is a crucial consideration for us.
Absolutely crucial. Considering where these infections occur, the source states that the lower extremity is the most common site of occurrence for necrotizing soft tissue infection generally. However, an increased incidence in the upper extremities has been seen specifically in the parenteral drug abuse population, likely directly related to injection practices providing a portal of entry. But it is critical to remember that any location of the body can be affected. The source specifically mentions the abdominal wall of neonates, which can occur in association with omphalitis, an infection of the umbilical stump.
Delving further into specific anatomical sites, the involvement of the scrotum and perineum in males is known as Fournier's gangrene. This is essentially necrotizing fasciitis, specifically affecting the superficial perineal fascia. The infection in Fournier's can spread extensively through specific fascial planes. It can spread to involve the penis and scrotum by tracking along Buck's fascia, Dartos's fascia, or Scarpa's fascia. Notably, Scarpa's fascia provides a pathway for the infection to spread superiorly up onto the abdominal wall.
And the source of these perineal infections is often a local process. Perianal or perirectal infections can spread into these areas. Undrained or inadequately drained perirectal abscesses are frequently cited as a source of Fournier's gangrene. It's also important to remember that perineal necrotizing fasciitis is not exclusive to males. It can and does occur in women as well, though the anatomy slightly alters the potential spread patterns.
Okay, that gives a good picture of who is at risk and where we typically see these devastating infections. To recap Section 4, primary risk factors are any skin trauma and key comorbidities like diabetes, obesity, alcoholism, smoking, and IV drug use. Certain infections like chickenpox and medications like SGLT2 inhibitors are implicated. NSIs are controversially linked, possibly by dampening immune function, although a direct causal link from simple use is unlikely. Immunosuppressants like anakinra also clearly increase risk. While the lower extremity is commonest, any site is possible, including neonatal abdominal wall and the perineum Fournier's gangrene, which spreads along specific fascial planes, often originating from local infections like perirectal abscesses.
Well summarized. Now let's move to Section 5, differential diagnosis. For the treating physician facing a potentially serious soft tissue infection, the most critical objective is early identification and treatment. The source powerfully states, time is tissue.
That phrase really captures the urgency, doesn't it? Immediate initiation of appropriate broad-spectrum antibiotic therapy and prompt surgical debridement are absolutely essential. Any delay in implementing these core interventions will inevitably lead to rapid spread of the infection, swift patient deterioration, and the onset of systemic sepsis. So, recognizing necrotizing soft tissue infection quickly amidst other conditions that might look similar initially is paramount.
This makes the differential diagnosis incredibly important. The most typical condition to differentiate from is cellulitis, a more superficial skin infection. The source notes that cellulitis may, in some cases, even be a precursor of necrotizing fasciitis. It can evolve. Another key differential is erysipelas, which is characterized by its erythematous, raised, and often very well delineated border, contrasting with the more diffuse and rapidly changing appearance of necrotizing soft tissue infection.
But it's not just differentiating from less severe infections, is it? The source lists other serious entities that must be considered in the differential. These include clostridial myositis and myelonecrosis, which, as the name suggests, involve muscle destruction, and non-clostridial myositis and myelonecrosis. Toxic shock syndrome, which, as we discussed with group A streptococcus, can actually occur concurrently with necrotizing fasciitis, is another crucial differential or co-diagnosis. Other possibilities include zygomycotic gangrenous cellulitis, caused by fungi, and mixed aerobic-anaerobic necrotizing cellulitis.
The source also specifically mentions two severe skin conditions that need to be differentiated, particularly relevant in pediatric populations or those with medication exposures. Toxic epidermal necrolysis, also known as Lyell's disease, is a severe skin reaction usually triggered by particular medications and must be differentiated from infectious causes like necrotizing soft tissue infection. And staphylococcal scalded skin syndrome, also known as Ritter's disease, is caused by exfoliative toxins produced by Staphylococcus aureus. The source notes that these latter two conditions, toxic epidermal necrolysis and staphylococcal scalded skin syndrome, are most common in neonates and children under 5 years of age.
Are there specific clues in neonates that might help distinguish NSTI?
Yes, the source highlights a crucial visual cue in neonates with omphalitis, that infection of the umbilical stump. Violaceous discoloration of the skin around the umbilical area appears to be a strong marker indicating the possible emergence of necrotizing fasciitis of the abdominal wall in this vulnerable population. Seeing that specific color change should immediately raise suspicion high.
And some organisms can lead you towards specific differential diagnoses based on exposure history, correct? For instance, Vibrio vulnificus infections quite commonly cause a blistering infection. These should be suspected in patients who have either been swimming in warm marine waters, such as along the Gulf of Mexico, or have been eating raw shellfish from that area, particularly oysters.
Exactly. Similarly, Aeromonas infections also occur following open wounds acquired in seawater. Another rare but distinct entity is cutaneous anthrax, which may present with a blackened central area, the eschar, surrounded by significant edema, providing a very specific visual clue if you see it.
So, while simple cellulitis is the most common mimic, staying vigilant for these other, often more severe conditions is vital to avoid delays in diagnosis and critical treatment.
Absolutely. To recap Section 5, early identification is crucial because time is tissue. The differential starts with distinguishing from cellulitis and erysipelas, but extends to other severe conditions like clostridial and non-clostridial myositis, toxic shock syndrome, which can co-occur, zygomycotic cellulitis, 10N, and SSS. Specific clues include violaceous skin changes in neonatal omphalitis and blistering infections with marine exposure, Vibrio aeromonas, or the characteristic eschar of cutaneous anthrax.
Okay, let's move to Section 6, clinical presentation. How do these patients typically present?
Patients typically present with a chief complaint of pain and swelling in the affected area. This may or may not be accompanied by systemic signs like fever and chills, especially early on.
The challenge in early presentation is that it can look deceptively benign, can't it? A focus of cellulitis may be apparent initially, leading to potential misdiagnosis. However, in some critical instances, very early in the course, there may be few, if any, visible skin changes on the surface. Yet in these patients, the classic, often described as pathognomonic, sign is present. Pain that is significantly out of proportion to the apparent skin findings. This sign is a direct consequence of the infection primarily affecting the deep fascial layer, not necessarily the skin itself, where the visible changes are minimal.
This discrepancy between severe pain and subtle skin findings is a crucial red flag. You really have to listen to the patient's description of the pain. In other patients, the manifestations may be more obvious, presenting as a large phlegmon, a diffuse, swollen area of inflammation. But even then, the area of infection might be mistaken for simple cellulitis rather than a more serious infection. As the disease progresses rapidly, the severe pain may actually transition to numbness. This occurs as a result of compression and damage to the nerves that also pass through those involved fascial layers.
That progression from severe pain to loss of sensation is a really worrying sign of nerve involvement, isn't it? With time, as the source notes, the infection will rapidly spread, leading to blistering and bully formation on the skin surface. Hints of darkening of the skin may begin to appear as perfusion decreases to the overlying tissue, progressing to obvious areas of dermal ischemia. The skin can transition from its normal color or erythema to dusky, then grayish, and eventually, frankly, black as tissue necrosis becomes evident.
These progressive skin changes are highly characteristic of necrotizing soft tissue infection. They are late signs, but very indicative. The definitive clinical diagnosis can often be made directly during surgical exploration or debridement. When the operating surgeon visually examines the fascia, if it is necrotic, it will give way easily to a probing gloved finger or a surgical clamp. That lack of normal tissue resistance and integrity in the fascia is a hallmark intraoperative finding. It's often described as dishwater pus or easily separable planes.
The source also mentions a more objective assessment tool that can support the clinical diagnosis: tissue oxygen saturation measured by near-infrared spectroscopy. Studies using this technique have suggested that the limbs of patients with necrotizing fasciitis, compared to those with only cellulitis, have markedly reduced tissue oxygen saturations throughout the involved site.
Yes, specific data supports this. In studies utilizing near-infrared spectroscopy, oxygen saturations in the involved site have been measured as low as 52% plus or minus 18% range, a significant drop compared to control measurements of 86% plus or minus 11% taken from uninvolved sites on the same patient or in control subjects. This objective finding really reinforces the underlying pathophysiology of profound tissue hypoxia in the affected area. It confirms what we think is happening biologically.
The source also provides specific details on presentations in neonates, which sound particularly devastating. Necrotizing fasciitis of the abdominal wall in neonates can occur as a complication of omphalitis in 10 to 16% of cases. Tragically, it carries a mortality rate of over 50%, even when treated with aggressive debridement of the involved skin, subcutaneous tissue, and fascia, highlighting the extreme severity in this population.
It's a critical presentation to recognize swiftly. To recap Section 6, the clinical presentation often starts with pain and swelling. Early, the skin changes may be minimal, making the classic pain out of proportion sign a crucial red flag, stemming from deep fascial involvement. Pain can progress to numbness. Later signs include rapid progression of skin changes like blistering, bullae, and discoloration, dusky gray-black, due to dermal ischemia and necrosis. Definitive diagnosis is often made intraoperatively by finding necrotic fascia. Objective data like low tissue oxygen saturation via near-infrared spectroscopy supports the diagnosis. In neonates, abdominal wall necrotizing soft tissue infection presents as a complication of omphalitis with violaceous skin discoloration and carries a tragically high mortality.
Okay, now let's move to Section 7, diagnostic considerations. Beyond a high level of clinical suspicion, which remained absolutely paramount, a number of specific diagnostic observations and tools can facilitate the confirmation of a suspected necrotizing soft tissue infection. It's particularly important to note, as you mentioned, that immunocompromised patients significantly add to the diagnostic complexity.
Yes, they really do. They often have atypical clinical presentations compared to immune-competent patients. Their signs and symptoms might be blunted or different. This variability in how the disease manifests can lead to further delays in initiating prompt treatment and supportive care, delays that are especially detrimental given the rapid progression of necrotizing soft tissue infection. As a consequence, a twofold increase in mortality is often observed specifically among immunocompromised patients who develop these infections.
So diagnosis is harder and outcomes are significantly worse in that population. What's considered the definitive diagnostic step when suspicion is high?
A definitive diagnosis, particularly early in the evaluation of a suspect lesion, may be achieved with a frozen section soft tissue biopsy. The source emphasizes that obtaining this biopsy is imperative when there is diagnostic uncertainty, as it provides immediate histological confirmation of a necrotizing process while the patient may still be on the operating table. Deep tissue cultures for aerobes, anaerobes, and fungi should also be obtained at the time of surgical debridement. This is also imperative because, as noted earlier, up to 75% of patients in some series have shown polymicrobial etiologies, and identifying these organisms is crucial for tailoring antibiotic therapy later on.
And the fungal cultures. You mentioned those are especially important in certain groups.
Absolutely. Fungal cultures are particularly important to obtain in specific high-risk patient populations, including immunocompromised patients, diabetic patients, and cancer patients. They are also crucial in patients who have not responded as expected to standard antibacterial and antibiotics, suggesting non-bacterial or co-fungal etiology might be at play. Considering fungal etiologies in these groups is a critical diagnostic step you don't want to miss.
What role do imaging studies play? Should we always get a CT or MRI?
The source provides strong guidance here. Delaying surgical intervention solely for the purpose of obtaining imaging studies is explicitly contraindicated when clear clinical signs of crepitus, that crackling sensation of gas in the tissues, or a worsening physical examination are present. Clinical suspicion and the need for immediate surgical source control trump the need for imaging in these acute, rapidly deteriorating situations. Surgery first.
But imaging can be useful in other circumstances.
Yes, definitely. When imaging is appropriate and doesn't cause undue delay, or is needed to assess the full extent of the disease, the source considers a CT scan the best initial diagnostic modality for necrotizing soft tissue infection. This preference is due to CT's high specificity for findings associated with the disease and its relative expediency and availability in many centers compared to other imaging options like MRI. A significant advantage of CT is its superior detection of soft tissue gas compared to MRI, and gas is a key sign in many types of necrotizing soft tissue infection.
What about the limitations of MRI? Why isn't it preferred initially?
MRI, while providing excellent soft tissue detail, has been shown to overestimate the extent of deep tissue involvement in necrotizing soft tissue infections. All that inflammation can look like more extensive infection than is actually present. This can potentially blur the distinction between necrotizing cellulitis and true deeper tissue infection like fasciitis or myositis. The source gives examples of key CT findings from a study of 20 patients with necrotizing fasciitis. Atypical fascial thickening with asymmetric swelling, at least twice the contralateral side, along with associated fat stranding, was seen in a high percentage, 80%, of these patients.
And the gas tracking, that's a classic sign people look for.
Yes. Gas tracking along fascial planes, a classic sign, was observed in 55% of these patients on CT. Characteristically, in this specific series finding, the infection did not involve muscle initially. The lack of abscess formation was also noted in this study, suggesting the infection was spreading diffusely along fascial planes rather than forming contained collections. The authors of that study noted that the areas of black, gangrenous skin visible externally were often far smaller than the actual widespread infection found in the underlying fascial planes on imaging and surgery, reinforcing the concept of pain out of proportion and the hidden nature of the disease extent. Importantly, though, 7 of the 20 patients in this series did have associated deep space abscesses, which required immediate surgical drainage.
So CT can really help guide surgery by identifying these hidden collections or mapping the full extent of spread that might not be obvious clinically.
Exactly. This demonstrates the value of CT studies in assessing the full extent of the disease, particularly in patients who are not responding as expected to initial therapy, or where the initial debridement may not have fully captured the extent. The source reiterates the limitation of MRI for rapid diagnosis, stating they tend to overestimate the disease state and, more importantly, typically introduce delays and are not as expedient as CT studies, solidifying CT as the preferred initial imaging modality when needed and when safe to obtain.
The source also discusses a specific scoring system, the Laboratory Risk Indicator for Necrotizing Fasciitis, or LRNIC score. This score was designed to predict the likelihood of necrotizing fasciitis and has gained some popularity. However, it's crucial to note, as the source points out, that despite its development back in 2004, it has not yet been fully validated across different patient populations or healthcare settings, which is a significant limitation we need to keep in mind.
That's a very important caveat. The score utilizes 6 specific laboratory indicators obtained on admission to calculate a risk score. These indicators are serum glucose greater than or equal to 180 milligrams per deciliter, C-reactive protein greater than or equal to 250 milligrams per liter, creatinine greater than or equal to 1.6 milligrams per deciliter, a white cell count either less than 15 or greater than 25 times 10 to the 9th per liter, hemoglobin less than 13.5 grams per deciliter for men or less than 11.5 grams per deciliter for women, and serum sodium less than or greater than 135 millimoles per liter. Each of these parameter deviations from normal are assigned points individually to generate the score.
What do these lab parameters reflect clinically? Why these 6?
These laboratory parameters reflect various aspects of the patient's systemic response to severe infection, including hyperglycemia, stress response to diabetes, markers of inflammation, CRP, renal dysfunction, creatinine from dehydration or sepsis, white blood cell response, either very high or sometimes low and overwhelming sepsis, anemia, hemoglobin reflecting inflammation, blood loss or other factors, and electrolyte imbalance, sodium, often related to fluid shifts. They essentially capture systemic derangement commonly seen in severe sepsis and significant tissue damage.
And the reported predictive value, how well does it work, according to the source?
For a LRNX score greater than or equal to 6, the positive predictive value, meaning the probability that a patient with this score truly has necrotizing fasciitis, is reported at 92%, pretty high. The negative predictive value, the probability that a patient with a score less than 6 does not have necrotizing fasciitis, is reported at 96%, also quite high. However, despite these apparently good numbers, the source explicitly states that its use alone as a diagnostic tool is not advocated. It really should be used in conjunction with clinical assessment, not replace it.
Have there been modifications to the score since its introduction? Has it evolved?
Yes, modified versions of the LRNEC have been developed. This was primarily done because the original LRNEC failed to consider important clinical parameters such as the patient's age, the specifics of their clinical presentation, their overall comorbidities, and other parameters that are typically included in more comprehensive and validated severity scoring systems like Apache 2 or Glasgow Coma scales, which are commonly used in critical care settings. The modified LRNet attempts to incorporate additional clinical and laboratory parameters to address some of these limitations of the original score.
And how is the LRNX score being used or interpreted in more recent studies? Is its role changing?
It seems so. More recent studies appear to suggest that LR9's primary utility is shifting. It's seen more akin to predicting associated necrotizing soft tissue infection mortality and amputation risk, rather than serving as a definitive diagnostic tool for the condition itself. Nevertheless, the source concludes that it remains a useful tool when combined with a high clinical suspicion, especially in situations where there is diagnostic uncertainty, serving as an additional piece of objective information to help guide complex decisions. It's one more piece of the puzzle.
Okay, that was a thorough look at the diagnostic process. To consolidate Section 7, diagnosis requires high clinical suspicion, especially challenging in immunocompromised patients with atypical presentations and higher mortality. Definitive diagnosis relies on imperative frozen section biopsy and deep tissue cultures. Aerobes, anaerobes, fungi, particularly in high-risk groups, are non-responders. Imaging, when not causing surgical delay, favors CT over MRI for its specificity, expediency, and gas detection, showing signs like fascial thickening, fat stranding, and gas tracking. MRI can overestimate involvement and cause delays. The L-Rhinex score, using 6 lab parameters reflecting systemic response, glucose, CRP, creatinine, WBC, HGB, NA, can be supportive, high predictive values for score 6. But is not advocated as a standalone diagnostic tool, and its role may be shifting towards predicting mortality implication risk rather than primary diagnosis.
Excellent. Now let's move into Section 8, clinical management, with a focus on adjunctive hyperbaric oxygen therapy. The source strongly reiterates that the absolute cornerstones of management for necrotizing soft tissue infections are broad-spectrum empiric parenteral antibiotic coverage and prompt, aggressive surgical debridement. Surgical debridement remains absolutely essential to early management and is considered the undisputed mainstay of therapy. No question about that.
The source mentions a diagram, Figure 1, illustrating the need for risk stratification to triage patient care, underscoring that patient severity guides the intensity and location of treatment. A critical point raised in the source is that despite the fundamental importance of antibiotics and surgical debridement, definitive evidence-based best practice guidelines for the overall management of necrotizing soft tissue infections still do not universally exist.
This absence of high-level consensus guidelines really speaks to the complexity and rarity of the disease and the inherent challenges in studying it rigorously. Regarding antibiotic use, the source advocates for the use of broad-spectrum antibiotics in all patients with suspected or confirmed necrotizing soft tissue infection. This should be initiated following blood cultures, but importantly, prior to obtaining the definitive tissue cultures during surgical debridement. You need to cover broadly first. Empiric regimens should be designed to cover the expected range of pathogens: anaerobes, gram-positive organisms including MRSA, and gram-negative organisms. Cast a wide net.
What are the typical empiric regimens suggested in the source?
Examples of specific regimens include a beta-lactamase inhibitor combination like piperacillin tazobactam or ampicillin sulbactam, or a carbapenem such as imipenem or meropenem. This broad-spectrum coverage needs to be combined with specific coverage against methicillin-resistant Staphylococcus aureus, MRSA, for which linezolid and clindamycin are mentioned. The source specifically highlights the use of clindamycin not only for MRSA, but also for its crucial role in providing coverage against toxin-releasing species of Streptococci or Staphylococci, like Group A Streptococcus. Clindamycin can inhibit protein synthesis and thus suppress the production of these dangerous toxins, which is a key benefit beyond just killing the bacteria.
And the duration of antibiotic therapy, that seems to be another area without clear consensus based on what you said earlier.
Yes, absolutely. The source notes that review of the literature suggests continuing the antibiotic regimen until no further debridements are required or until the patient reaches hemodynamic stability. However, there is indeed controversy. The source adds a prudent caveat. Avoidance of premature cessation of antibiotics is a reasonable approach given necrotizing soft tissue infections' potential for rapid deterioration and annulled or relapse. You don't want it coming back. Yet it also points to a study finding by Ferrex and colleagues, a multi-center review of 341 patients, which found that an extended duration of antibiotic therapy did not equate to better therapeutic outcomes. This finding, the source notes, further emphasizes the complexity and lack of current evidence-based guidelines regarding the optimal duration of antibiotic use. We just don't have a definitive answer on how long is long enough.
The source also briefly touches on post-exposure prophylaxis for contacts. Antibiotic therapy for immunosuppressed close contact patients remains a point of controversy. For instance, the utility of post-exposure prophylaxis with 10 days of penicillin remains uncertain. Although it's considered reasonable for those specifically exposed to necrotizing soft tissue infection patients with confirmed group A streptococcus, given the virulence of that organism and its potential for spread.
Right, a specific consideration for GAS. Now we arrive at the key adjunctive therapy highlighted in this text, hyperbaric oxygen therapy. The source acknowledges that the immediate use of adjunctive hyperbaric oxygen therapy in the treatment of necrotizing soft tissue infections remains a point of contention, particularly concerning the logistical challenges and safety of transferring critically ill patients to a facility equipped with a hyperbaric chamber. That's often a major practical hurdle.
Despite this practical debate, the source strongly asserts that despite an acknowledged paucity of large, definitive randomized clinical trials, RCTs, numerous studies have continued to demonstrate the beneficial effect of adjunctive hyperbaric oxygen therapy in the immediate management of necrotizing soft tissue infections. The authors acknowledge the inherent limitations in conducting large RCTs for such a rare, complex, and severe disease. It's ethically and logistically difficult to withhold a potentially life-saving therapy or standardized care across sites for such a rapidly evolving critical illness. It's just very hard to study properly.
It really is. Let's examine the evidence presented in the source supporting HBO2 use because there is quite a bit discussed. A systematic review by Thrain and Ovison in April 2019 focused on the efficacy of hyperbaric oxygen therapy for necrotizing soft tissue infection, with mortality as the primary outcome. They used PRISMA guidelines for their search and analyzed studies using a modified Delphi statistical method to mitigate bias in the predominantly non-randomized literature.
And what did they find in that review?
Well, out of over 1,700 studies, only 21 met their criteria, 19 of which were case control series, which really illustrates the limited high-level evidence. They found significant variability across these studies in treatment regimens, HBO2 duration and frequency, other adjunctive therapies used, and patient selection criteria. A real mix. Mortality was the only consistently reported variable across all included studies. Their analysis found a positive association between HBO2 therapy and reduced mortality in all but 3 studies they looked at. However, they concluded by reiterating the need for more high-quality RCTs, again acknowledging the difficulty of conducting them for this condition.
Another systematic review mentioned is by Gore, specifically on odontogenic necrotizing soft tissue infection, those starting from dental sources treated with surgery, plus parenteral antibiotics, plus HBO2.
Yes, the Gore review also demonstrated reduced mortality rates in patients receiving HBO2, consistent with most studies in the Thrain and Ovison review. However, interestingly, the Gore review did not find a statistically significant decrease in mortality, specifically when HBO2 was compared to surgery plus parenteral antibiotics alone. The authors of that review underscored the absolutely critical role that surgical debridement plays in reducing morbidity and mortality, suggesting HBO2 is a beneficial adjunct, perhaps, but not a replacement for essential surgery. Surgery is king.
The source then discusses a more recent large effectiveness model multicenter randomized clinical trial from 2022 by Miller et al. Now, this study focused on severe lower limb trauma, not strictly necrotizing soft tissue infection, but it demonstrated favorable limb salvage outcomes in patients with severe open tibial fractures treated with HBO2. It involved 10 hospitals globally and included adult trauma patients with severe Gustilo grade 3 open tibial fractures.
It's noted that trial-related standardization of overall trauma care wasn't uniformly instituted across all sites, which implies some variability in care alongside the HbO2. That's a limitation. The HbO2 protocol involved pressurization to 2.4 or 2.8 atmospheres absolute for 80 to 100 minutes. The number of HbO2 sessions was standardized by the protocol to 12 treatments over approximately 9 days, starting as early as possible after enrollment.
And what were the key findings from this severe trauma trial that might be relevant to necrotizing soft tissue infection?
The findings emphasize that early implementation of hyperbaric oxygen therapy in this patient population reduced tissue necrosis, minimized the likelihood of long-term infectious complications, and improved bone union and functional outcomes post-injury. While it is a trauma study, the mechanisms regarding tissue viability and infection control certainly have relevance to necrotizing soft tissue infection, where tissue survival is paramount. The authors suggested future research to refine the optimal HbO2 oxygen dosage.
Okay, let's look at a historical retrospective cohort study by Wilkinson and Dillette, which specifically examined necrotizing soft tissue infection itself. They looked at survival to hospital discharge, limb salvage, and long-term survival after discharge using logistic regression analysis. What did they find?
Their analysis yielded a powerful finding. The strongest association with survival was the intervention of hyperbaric oxygen, with a statistically significant p-value of 0.02. Hyperbaric oxygen therapy in their study increased survival with a strong odds ratio of 8.9, although the 95% confidence interval was quite wide, from 1.3 to 58.0. Still, a strong signal. They calculated a number needed to treat to benefit of 3, meaning treating just 3 patients with HbO2 was associated with preventing 1 death in their study population.
Wow, a number needed to treat of 3 is remarkably impactful for a severe condition like this. That's a strong argument.
It is indeed. Their study also found that HbO2 therapy reduced the incidence of amputation and improved long-term outcome, p-band 002. This finding is supported by another historical series by Escobar et al., mentioned in the source, where there were no further amputations beyond those already done prior to transfer once hyperbaric oxygen therapy was initiated in their series of 42 NSTI patients. Suggests it might halt progression.
Now, the source also brings up a specific historical retrospective review from 1994 by Brown et al., a multi-center review of 54 patients. But it critiques it pretty significantly, doesn't it?
Yes, the source highlights major flaws in the Brown et al. Study, and it's important to understand these because this study is often cited by skeptics. There were numerous discrepancies in the demographics of the 2 patient groups compared to the hyperbaric treated group and the non-hyperbaric treated group. Critically, half of the hyperbaric group, 30 patients from one site, had clostridial infections, known for their severe toxins and high mortality, whereas the non-hyperbaric group, 24 patients, had only 4 clostridial infections. 6 of the 30 in the hyperbaric group even had clostridial myositis and myonecrosis, that's 17%, while only 1 in the non-hyperbaric group did.
So they weren't truly comparing similar patient populations or infections at all. Apples and oranges, really.
Exactly. The source explicitly states, hence, this clearly shows the same diseases were not being compared in this study. That's a fundamental flaw. Furthermore, there were significant discrepancies in the HbO2 treatment protocols used. Most patients, 80%, received 4 or fewer treatments, and the maximum was only 7. That's very few. The timing was not specified, and standard recommended gas gangrene or NSTI protocols, multiple treatments in the first 24-48 hours, then twice daily, were clearly not followed. Treatment durations were much shorter than typical protocols or other studies showing benefit averaging less than a day and a half for gas gangrene patients and around 2 days for others, compared to a median of 8 treatments in the Wilkinson study. They basically underdosed the therapy.
Given these pretty major flaws, what about their mortality finding? Did it show anything meaningful?
Well, the Brand study found a mortality difference, 30% in the hyperbaric group versus 42% in the non-hyperbaric group, but it was not statistically significant. The authors of the source text conclude that the Brown et al. Conclusion that HbO2 for truncal necrotizing fasciitis is controversial is in fact faulty.
Why faulty? Just to be clear.
Faulty because the statistical mortality comparison is unreliable due to the profound heterogeneity of the groups and the differing severity of the infections being compared. You can't draw valid conclusions from comparing such different groups. The small sample size and mixed diagnoses also rendered the study insufficiently powered to detect a statistically significant result even if one existed. The source further notes the study doesn't inform the use of HbO2 for limb or non-truncal NSTI, as their HbO2 group was heavily skewed towards truncal clostridial infections. The key takeaway here, as the source emphasizes through its critique, is that this widely cited historical study is fundamentally flawed and should not be used as valid evidence to argue against the potential benefit of hyperbaric oxygen therapy for necrotizing soft tissue infection. It's important to know the weaknesses of that study.
That provides really important context for evaluating that historical study. Let's turn to a large 2021 meta-analysis that reviewed literature from the past 5 years. That sounds more current.
Yes, this meta-analysis analyzed a very large data set of necrotizing soft tissue infection patients. It notes that in reported series without hyperbaric oxygen therapy, there's a marked increase in amputation rates, ranging widely from 16.9% up to 66%. Huge range, but high. Mortality in reported series without HBO2 is also higher, ranging similarly from 16.9% up to 66%. The meta-analysis itself published findings on 48,744 patients with necrotizing soft tissue infection. A smaller proportion, 2.5%, received hyperbaric oxygen therapy compared to 47,507 patients who did not.
That's a massive number of patients. What did this analysis show regarding in-hospital mortality? That's a key outcome.
The analysis demonstrated a reduced in-hospital mortality of 9.8% in the HBO2 group, with a pooled odds ratio of 0.44, with a 95% confidence interval of 0.33 to 0.58. This showed a strong, statistically significant benefit in favor of hyperbaric oxygen therapy for reducing mortality. For major amputations, the pooled odds ratio was 0.60, with a 95% confidence interval of 0.28 to 1.28. This trended in favor of HBO2, but the confidence interval crossed 1, meaning it was not statistically significant for amputation in this specific large analysis, unlike the clear mortality finding.
Interesting difference there. What was the overall conclusion from this large meta-analysis then?
They concluded that, although the most effective oxygen dose remains to be known, their extensive data appears to suggest that necrotizing soft tissue infection treated with hyperbaric oxygen therapy have reduced odds of dying during the sentinel event and may be less likely to require a major amputation.
Yeah.
They acknowledge that clinical evidence for the generalizable effectiveness of HBO2 therapy in NSTI remains somewhat sparse compared to other interventions, as noted in the 2015 Cochrane review. There aren't many big RCTs. However, they highlight that this meta-analysis represents the most comprehensive analysis to date on the effects of HBO2 therapy in NSTI, given the huge number of patients included.
And the number needed to treat from this meta-analysis, how does it compare to the Wilkinson study?
They reported a number needed to treat of 19 in order to prevent 1 death based on their analysis. That's higher than the NNT of 3 from Wilkinson, but still indicates a meaningful benefit given the condition's severity. The authors also addressed potential historical bias, reiterating that despite poor methodology identified with some older studies included, a chronological assessment of the odds ratios did not suggest a historical bias where older studies skewed the results more favorably for HBO2. The overall estimate of benefit with HBO2 therapy, they conclude, appears to remain stable over time across the literature, supporting the findings. The source also reviews evidence for HBO2 use in specific scenarios. In neonatal necrotizing soft tissue infection, associated conditions mentioned include omphalitis, balanitis, mastitis, postoperative complications, and invasive fetal monitoring. A literature review cited found that 4 of 6 neonatal cases who received hyperbaric oxygen therapy survived, while the overall mortality rate in the reviewed cases without HBO2 was high, 39 out of 66, that's 59%.
And specifically for neonatal omphalitis with abdominal wall necrotizing fasciitis, you mentioned that's particularly deadly.
Yes, the source presents a stark contrast from a study out of Children's Hospital Los Angeles, focusing on neonatal omphalitis patients with abdominal wall necrotizing fasciitis. None received hyperbaric oxygen therapy, and 7 out of 8 cases died for a staggering mortality rate of 87% without HBO2 therapy. Just devastating. In contrast, in a series of 32 cases of omphalitis from Seattle, 7 developed necrotizing fasciitis, and 5 of those 7 died. However, 4 of those 7 received hyperbaric oxygen therapy, and the 2 patients who survived were among the 4 who received HBO2 treatments. These 2 survivors were also noted to have resolved their systemic sepsis more rapidly and required no further debridements before their wounds were definitively closed, suggesting better tissue viability and infection control.
That difference in outcomes in neonates is quite compelling, even with small numbers. What about Fournier's gangrene and HBO2?
For Fournier's gangrene cases, the source mentions the Fournier's gangrene severity index score, which was developed to assess physiological variables and correlate with patient mortality. A study from Duke University analyzing 50 consecutive patients over 15 years had an overall mortality of 20%. 3 statistically significant predictors of outcome on univariate analysis were identified: the extent of infection, the depth of the necrotizing infection, and importantly, treatment with hyperbaric oxygen.
So hyperbaric oxygen therapy was a positive predictor of survival in that Fournier series as well.
Yes, it was. Adjunctive benefits of hyperbaric oxygen therapy have also been demonstrated in systematic reviews specifically related to Fournier's gangrene. In one such article, the authors describe synergistic efficacy of HBO2 therapy when combined with negative pressure wound therapy, a technique often used for managing complex soft tissue wounds after debridement. Makes sense they'd work well together. These authors argue, mirroring the sentiment in the source text, that the lack of large RCTs should not be a reason to withhold potentially beneficial adjunctive measures like HBO2 that can assist with healing and minimizing morbidity in challenging NSTI cases like Fournier's.
And is hyperbaric oxygen therapy specifically advocated for Fournier's gangrene based on this?
Yes. Adjunctive hyperbaric oxygen therapy, coupled with early surgical debridement and empiric broad-spectrum antibiotic coverage, has been advocated by several authors, specifically in the management of Fournier's gangrene. Recapping the mechanism in this context, HBO2 has been shown to halt tissue-laden anaerobic bacterial growth, limit tissue necrosis, and minimize systemic toxicity, all crucial in this rapidly spreading infection.
The source presents a specific retrospective series by Hollabaugh et al. From the University of Tennessee on 26 cases of Fournier's gangrene. What did that show?
In this series, of the 15 patients with identified sources, 8 had urethral disease or trauma, 5 had colorectal disease, and 2 had penile prosthesis issues. So, typical sources. All patients received prompt surgical debridement and broad antibiotics, with procedures like urinary fecal diversion and multiple debridements as needed, standard aggressive care. 14 of the 26 patients additionally received hyperbaric oxygen therapy.
And the outcome difference in that Tennessee series, was it significant?
It was. The group treated with hyperbaric oxygen therapy had a mortality rate of just 7%, compared to a significantly higher 42% in the group not receiving HBO2. That difference was statistically significant with a p-value of 0.04. The combined overall mortality in the series was 23%. The one patient who died in the HBO2 group died from an acute myocardial infarction, not the infection, after progressing well. So, arguably unrelated. In the non-HBO2 group, deaths were attributed to ongoing or fulminant sepsis directly related to uncontrolled infection.
The relative risk for survival in that study was striking then.
Yes, the relative risk for survival was calculated as 11 times greater, specifically in the group receiving hyperbaric oxygen therapy in the Tennessee series. A very strong association. This study, interestingly, did not show a decrease in the number of debridements needed in the HBO2 group, but the authors noted this was confounded.
How is it confounded?
It was confounded because a larger number of patients in the non-HBO2 group experienced delays in care due to various factors, preventing them from receiving further debridements, likely because they were too unstable or died before they could get back to the OR. The source clarifies that the delay to initial treatment itself was not a factor that differed between the groups, implying similar initial timing, but subsequent differences in the ability to perform repeat debridements in the non-HBO2 group due to their poorer clinical trajectory.
Okay. Let's address the significant practical concern with HBO2 for these critically ill patients, timely access, and the issue of transfer. The source notes that the challenge of timely use and access to adjunctive hyperbaric oxygen therapy is often raised as a concern and cited as a reason to potentially avoid using it, even by facilities otherwise equipped to care for critically ill NSTI patients.
Yes, absolutely. Despite the favorable risk-to-benefit ratio often cited for appropriate HBO2 use, this concern about logistics and potential transfer delays persists in the literature and clinical discussions. It's a real-world problem. Some authors, the source mentions, have even argued that using HBO2 is futile precisely because of possible therapeutic delays and complications that might result from transfer attempts.
But the source presents evidence that counterpoints this argument about transfer specifically being the issue, doesn't it?
Crucially, yes. The source highlights that multiple studies have shown a correlation with an increase in morbidity and mortality when patient transfer is involved, and this holds true irrespective of whether hyperbaric oxygen therapy use is involved. This observation weakens the argument that HBO2-related transfer is uniquely problematic. Instead, it emphasizes the inherent risk of transferring any critically ill patient with a time-sensitive condition like sepsis or NSTI. This finding, the source argues, underscores the need to increase hyperbaric chamber availability and access at a greater number of hospital-based critical care centers rather than allowing logistical challenges to preclude a potentially beneficial therapy for this debilitating disease. Make it more accessible, basically.
The source points out that access to HbO2 continues to be argued as a major confounder in studies, making it difficult to definitively isolate the benefit. However, a multicenter prospective study published in 2021 by Bruin et al. Provided a different perspective. All participating hospitals were referral centers for necrotizing soft tissue infection with readily available hyperbaric oxygen therapy, minimizing the transfer issue as a confounder. What did they find?
In that study, assessing multiple variables impacting morbidity outcomes, the use of hyperbaric oxygen therapy was associated with the highest odds ratio for improved outcome, suggesting a strong benefit when readily accessible when transfer wasn't the issue. This trend was also demonstrated by Shaw et al. In a large multi-center retrospective review of 1,583 patients treated at 14 HbO2-equipped facilities between 2008 and 2010.
What were Shaw et al.'s key findings, particularly in the sickest patients? That seems important.
They found that specifically in patients categorized high validated severity of illness scores, the ones most at risk, the use of hyperbaric oxygen therapy was associated with significantly fewer deaths, 4% center-free percent P4.1, and fewer complications, 45% and 66% P.01. Very significant differences in the sickest group. Similar trends in survival benefit are noted to be seen in other studies referenced in the source text Table 1.
This reinforces the idea that the sickest patients may benefit most, and timely access is key. The source also stresses the impact of timing itself.
Absolutely. An important consideration regarding the lack of survival benefit identified in some studies is directly linked to the time to initiation of hyperbaric oxygen therapy. When was it started? Delayed use of adjunctive HbO2 often correlates with poor outcomes. In these situations, the intervention might be better characterized as a delayed salvage attempt, rather than a timely intervention initiated early in the disease course when it might have had more impact. The source emphasizes that when direct access to a hyperbaric facility removes the delay associated with transfer concerns, survival benefit appears to coincide, aligning with findings from centers with readily available HbO2, like those in the Bruin et al. And Shaw et al. Studies.
And the author's conclusion on cost effectiveness. Does the benefit justify the resource use?
The authors of the source text conclude that the use of hyperbaric oxygen therapy as an adjunct to current standard practices for management is cost-effective and life-saving, particularly for patients with elevated severity of illness scores, where the potential benefit strongly outweighs the resource utilization.
Wow, that was an incredibly extensive look at the management and the evidence for hyperbaric oxygen therapy. So, to consolidate this crucial Section 8, the cornerstones are broad-spectrum empiric antibiotics, targeting anaerobes, gram-positives, including MRSA, gram-negatives with clindamycin added for toxin suppression, and essential prompt surgical debridement, acknowledging the lack of definitive guidelines for the latter specifics. Antibiotic duration is debated, often continued until no further debridement or stability, avoiding premature cessation despite some data suggesting extended duration may not always help outcomes. Adjunctive hyperbaric oxygen therapy is presented as an accepted modality despite limited RCTs, justified partly by study difficulty. Evidence from meta-analyses like the 2021 one showing reduced mortality, NNT19, and cohort studies like Wilkinson showing NNT3 reduced amputation largely supports a survival benefit, particularly in severe cases. Shaw et al. Flawed historical studies like Brown et al. Should not be used to argue against it. Specific scenarios like neonatal NSTI and Fournier's gangrene show particularly promising HbO2 data. Concerns about transfer delaying HbO2 are noted, but transfer itself increases risk for any critically ill patient. The argument favors increasing HbO2 access and using it early where available without delaying surgery, or even before surgery if surgical delay is unavoidable, as timely initiation appears key. The authors view it as cost-effective and life-saving, especially for the sickest patients.
An excellent synthesis. Now we move to Section 9. Hyperbaric oxygen treatment protocol, outlining how HbO2 is typically administered in this context, according to the source text. The optimal candidates for hyperbaric oxygen treatments are patients who either have a confirmed diagnosis of a necrotizing soft tissue infection or are very high on the clinical differential diagnosis.
Are there specific patient types who should get the strongest consideration for it?
Yes. Patients who are critically compromised hosts, think immunocompromised, severely diabetic, etc., are noted to deserve the strongest consideration for hyperbaric oxygen therapy, as they are unfortunately more likely to experience worse outcomes with their infection compared to immune-competent individuals. The source explicitly states that significant organ failure itself is not considered a contraindication to treatment, provided, and this is key, the treating hyperbaric chamber facility is properly staffed and equipped to manage the specific complexities of the individual patient, especially those requiring mechanical ventilation and vasopressors. You need ICU-level care capability within or alongside the hyperbaric facility.
The source mentions Figure 1 again, illustrating a treatment algorithm that likely integrates these candidacy considerations into a workflow. What are the specific details of the typical HBOT treatment protocol outlined in the text?
The standard treatment protocol for necrotizing soft tissue infections, as outlined in the source, involves initiating hyperbaric oxygen therapy at a pressure of 2.0 to 2.5 atmospheres absolute, that's ATA. Each treatment session lasts for 90 minutes of oxygen breathing time. This is typically administered twice a day for the first few days. The endpoint for this initial, more frequent treatment schedule is clinical evidence that the extension of necrosis in previously debrided areas has stopped and the infection appears clinically controlled. You're looking for demarcation.
And if clostridial infection is suspected, is the protocol different then?
Yes, there's a specific modification for suspected or confirmed clostridial myositis and/or myonecrosis, or if the differential diagnosis remains unclear, but there's high suspicion for a gas-producing infection. In this situation, higher pressure treatments of 2.8 to 3.0 atmospheres absolute are warranted. The source specifies using the gas gangrene protocol in this scenario, which typically involves 3 treatments within the first 24 to 48 hours to rapidly leverage the direct inhibitory effect of hyperoxia on clostridial alpha toxin production and bacterial growth. Hit it harder and faster.
How is the treatment schedule adjusted as the patient hopefully stabilizes?
The source notes that some hyperbaric specialists may switch to once-per-day treatments once the patients appear clinically stabilized. The rationale for continuing treatment once daily is to help prevent relapse of the infectious process and to support healing, continuing until the patient is truly stable with no clinical or laboratory evidence of ongoing infection before finally stopping treatments altogether. The source advises, similar to the advice on antibiotic duration, avoidance of premature cessation of hyperbaric oxygen therapy to help prevent relapse. Don't stop too soon.
It's crucial to reinforce, as the source does repeatedly, that hyperbaric oxygen therapy is strictly an adjunct. It is not a substitute for the core components of standard care. These essential components include standard wound care, aggressive surgical debridement of necrotic tissue, which remains paramount, drainage of any fluid collections and abscesses, the use of antibiotics directed at the likely organisms and later culture-specific, the use of intravenous immunoglobulin, IVIG, particularly if the necrotizing soft tissue infection is associated with group A beta hemolytic streptococcal infection and toxic shock syndrome, where it can neutralize superantigens, and comprehensive goal-directed management of sepsis in the ICU.
This point cannot be overstressed. HBO2 supports these other critical therapies. It doesn't replace any of them. It's part of the package. Regarding contraindications, the source states there are very few absolute clinical factors that preclude the use of hyperbaric oxygen therapy. The only absolute contraindication mentioned is an untreated pneumothorax, due to the risk that it could develop into a life-threatening tension, pneumothorax, under increased ambient pressure in the chamber. That's the one thing you absolutely cannot have.
How is that risk managed or mitigated in practice, especially for sick patients?
The source considers it essential for providers caring for critically ill patients with necrotizing soft tissue infection to maintain a low threshold for placing temporary bilateral myringotomy tubes or ear tubes. This is particularly important in unconscious or intubated patients who cannot voluntarily equalize pressure in their middle ears. Placing these tubes allows passive equalization and prevents the most common side effect of hyperbaric oxygen therapy, which is autolytic barotrauma or pressure injury to the ears. It's a simple preventative measure. In patients with known obstructive pulmonary disease, it is important to compress and decompress the chamber with both slow descents and ascents to further minimize the risk of pneumothorax or air-trapping complications in the lungs. Careful pressure changes are key.
What about oncology patients receiving certain types of chemotherapy, which was mentioned earlier as potentially interacting?
Yes, for oncology patients with necrotizing soft tissue infection who are currently receiving certain chemotherapeutic agents, such as blomycin or doxorubicin, there are theoretical concerns about potential drug interactions that could lead to increased pulmonary or cardiovascular toxicity with hyperoxia. However, the source notes that individual prognostic considerations based on the patient's specific status and the severity of the necrotizing soft tissue infection are often made on a case-by-case basis. The source suggests that the small relative risks of potential pulmonary or cardiovascular toxicity from HbO2 may well be warranted and outweighed by the beneficial exposure risk when juxtaposed with the associated very high mortality risk posed by the necrotizing soft tissue infection itself. It's a crucial risk-benefit calculation focused on treating the immediate, life-threatening process first and foremost.
And revisiting the concern about treatment delays one more time, just to be crystal clear.
The source notes that avoiding delay in instituting immediate adjunctive hyperbaric oxygen therapy due to concerns related to other relative contraindications, such as a history of seizures or existing myopia, which can usually be managed, are considered misplaced deterrents. These conditions require management, not necessarily avoidance of potentially life-saving HbO2. Furthermore, concerns that hyperbaric oxygen treatments necessarily delay surgical intervention often do not reflect clinical practice. Hyperbaric treatments are frequently initiated after the first urgent operative debridement if timely access to the operating room can be achieved. Get the surgery done, then start HbO2. However, if an unavoidable delay in getting to the operating room does exist, the source explicitly advocates for immediate early access to hyperbaric oxygen therapy in a facility equipped for managing critically ill patients rather than waiting for surgery, based on the principle that timely intervention against the pathophysiology is critical.
Okay, that covers the specific protocol details and contraindications well. To consolidate Section 9, optimal HbO2 candidates have diagnosed or highly suspected NSTI, especially critically compromised hosts. Organ failure isn't an absolute contraindication if critical care support is available. The standard protocol is 2.0, 2.5 ATA, 90 minutes, twice daily until necrosis halts, around 7-10 treatments, then potentially once daily until infection is fully controlled, which could be up to 30 treatments. Suspected clostridial infection requires higher pressures, 2.8, 3.0 ATA, and an intensified initial protocol, 3 treatments in 24-48 hours. HB2 is strictly an adjunct to essential care. Wound care, debridement, drainage, broad antibiotics, including clindamycin for toxins, IVs, especially for gasts, and sepsis management. The only absolute contraindication is untreated pneumothorax, myringotomy tubes prevent common ear barotrauma, and slow compressions, decompressions are used for lung disease. For oncology patients on specific agents like bleomycin doxorubicin, the severe risk of NSTI typically outweighs theoretical HbO2 toxicity concerns in a risk-benefit analysis. Concerns about relative contraindications or HbO2 delaying surgery are often misplaced. Timely HbO2 is advocated either after initial surgery or before if surgical delay exists, provided critical care support is available.
Exactly. Finally, let's briefly address Section 10, utilization review, as discussed in the source text. During the acute phase of necrotizing soft tissue infections, as we've noted, twice-a-day hyperbaric oxygen treatments are typically advised. This frequency is continued until the clinical extension of necrosis has been halted.
And how long does it usually take to see that halting of necrosis, roughly?
The source indicates that this halting of necrosis is often clinically observed within approximately 7 to 10 treatments. However, due to the nature of this disease, its potential for relentless progression, and the possibility of undetected foci of necrosis, the treatment course doesn't necessarily stop at that point. These initial intensive treatments are often followed by once-daily treatments over a more extended period. The goal of this continued therapy is to ensure the infection is well controlled, meaning there's no clinical or laboratory evidence of ongoing spread or recurrence, and to promote tissue healing and granulation.
And that extended course can require quite a few treatments then.
Yes. The source states that up to 30 treatments may potentially be required to achieve this goal of complete infection control and support the later stages of recovery. The source also mentions a specific practice. Utilization review may be requested after 30 treatments. This suggests a checkpoint within that particular institution's protocol to evaluate the need for continuing therapy beyond that point, perhaps based on the patient's clinical progress and the assessment by the hyperbaric team and treating physicians. It's presented more as part of their process rather than a universal standard guideline across all centers, but it reflects the potential need for longer courses.
Okay, a brief recap for Section 10, utilization review. The acute phase typically involves twice daily HbO2 until necrosis stops, around 7-10 treatments. This is often followed by once daily treatments until infection is fully controlled, potentially up to 30 treatments. The source notes that utilization review might be conducted after 30 treatments in their practice as a checkpoint.
That brings us to the conclusion of our detailed exploration of this challenging topic, drawing extensively from the provided source material.
What an incredibly deep dive into necrotizing soft tissue infections. We've covered its rapid, devastating nature, the critical role of surgical debridement and broad antibiotics, the complex pathophysiology driven by hypoxia, the varied microbiology, the challenging diagnosis, and the substantial body of evidence, despite those RCT limitations, supporting adjunctive hyperbaric oxygen therapy, along with the typical protocols and contraindications. Understanding these details directly from the source text truly sharpens our clinical acumen and hopefully improves our ability to diagnose faster, make better treatment decisions, and ultimately impact patient outcomes in these critical situations.
Indeed, it really highlights the multifaceted nature of this disease. And perhaps a final thought to leave you with, building on the source material. Given the persistent challenges in conducting large, definitive randomized controlled trials for necrotizing soft tissue infection and hyperbaric oxygen therapy due to the inherent rarity and severity of the disease, how do we, as specialist clinicians operating in these time-sensitive, high-stakes environments, best integrate the existing diverse evidence, which is primarily from observational studies and meta-analyses, into our daily clinical practice? And perhaps what non-RCT study designs might be the most ethical and effective way forward to further refine treatment guidelines for this critical condition in the future?
That's a crucial question for the field and for our individual practice. How do we move forward with the best available evidence? We encourage you to revisit the source material, perhaps focusing on some of the specific studies mentioned or exploring areas of ongoing debate, like the optimal antibiotic duration or the evolving role of risk stratification tools like LRNAC. There's always more to learn.